Hey folks, Scott Weingart here, and this is an EMCrit We. This would have been a podcast, but my guest has conflicts of interest, so I can't give CME, so it's not a podcast, it's a we. But damn, it is a good we. So we did a malpractice case last year on a patient with like stone cold normal vitals who presented and turned out to be a PE, and the doctor was sued, and the main crux of the case was the ECG showed pretty significant T-wave inversions anteriorly and inferiorly, and that was missed by the doc involved as a sign of PE. And I made a mental note to myself, get the ECG cyborg named Pendle Myers on the show to discuss ECGs in pulmonary embolism. Now, Jeff Klein also mentioned this topic when we were talking about that malpractice case, and he said if you're not screening the ECG, then that is below standard of care. And so that was even more impetus to get this done. Now, if you don't know Pendle, he's been on the show before. He's basically the creator of the OMI paradigm, the replacement for the STEMI, and it can't come soon enough. STEMI's got to go. And he is brilliant. He was my resuscitation fellow. He was my resident. And from day one, he was just like a maven of all things cardiology and ECG. So brilliant. Love the guy. Real soft-spoken. Nice. You're going to love him too if you haven't heard him before. We'll get right into it in just a sec. Very quickly, the Out on Time asynchronous course has just been released. And we had done the synchronous beta version of the course to test out the ideas, and we got fantastic feedback. We went back for, I think, a year and actually took all the recommendations and then put them into this new course. Now, the purpose of this course is, as the name says, to get you out on time. And not out on time rushed, not out on time frazzled and miserable, but out on time relaxed and joyful so that you can get home to your family, your friends, and your life and not stay 2 hours after your shift. But at the same time, we want you to have perfectly supportable, billable charts, and we want you to have medical legally defensible charts. And we want you to be able to do it without losing the income from seeing patients. So it's a tall order, but I think we succeeded. We're going to get you out on time or damn close to it. Your charts are going to bill beautifully, and you're going to be safe if anyone takes a look at those charts with the desire to sue you. In addition to that, we have things like managing interruptions, managing flow, all the things that keep you efficient and happy on shift. It's all the stuff they should have taught you during your residency, and they never did. And I know they didn't because every time I talk to a residency and I just mention charting, they're like, oh, no one ever taught us charting. And I'm like, oh, God. Well, now there's a course for it. And if you want to check it out, it's Out on Time, all one word, Out on Time course, all one word, outontimecourse.com, outontimecourse.com. Check it out. If you have questions, let me know. I'm happy to answer them. But I think you're going to love it. And everyone who has been part of the beta test loved it. So check it out, outontimecourse.com. All right, let's get right into the episode on ECGs and acute pulmonary embolism with Pendle Myers. So tell the folks who you are and what you do. You've been here before, but this might be the first time people have heard you.
Hello, everyone. I'm Pendle Myers. I'm an emergency medicine doctor specializing in EKGs and critical care. I know Scott very well. I was his fellow back in, 2019, 2020?
Yep.
And I've long been listening to EMCrit and happy to be on.
Excellent. And now you are some form of cyborg. Now, was it actually just a brain implant that they placed in there to allow easier ascertainment of EKGs, or has there been additional enhancements?
You're exactly right. And it was not just any implant. It was Steve Smith's actual patented implant that got put right in my brain.
I was thinking about it. I'm like, no, I don't want to mess with this, the wetware. I'm not going to do it. But yeah, I understand the benefits of it. All right. And just as a conflict of interest, you are a partner in PM Cardio, which is the current, to my estimation, best AI integration into EKG readings out there. As it stands now, it will tell you if the patient has an MI, though it's not FDA approved, so it's only for informational purposes, for studies and such. You can't use it on clinical practice. I wanted you to come on the show because of a case that was recently posted. You actually did a blog post, which we'll link to, on this specific case. It was the case on the medical legal reviews, and the EKG on it, I think, would have been read by many ED docs as just non-specific T-wave changes, but texted it to you as soon as I figured I was going to do the post. And you're like, obviously, Scott, you and I both know this is going to be a pulmonary embolism. But you were very clear. I don't think most ED docs know that, and I don't think it holds the standard of care. And so we posted that case. We got a lot of feedback about people petrified now of missing EKGs in pulmonary embolism. And then I had just recently Jeff Klein on the show, and he does a ton of medical legal work on both sides, defense and plaintiff. And he's like, I just can't defend docs who don't look at the EKG and screen for PE on that EKG. I just can't take those cases successfully. So that scared me because that puts it in, I think, you were like, I don't think it's standard of care. And then you have Jeff Klein, the PE guy, saying not only is it standard of care, but it's indefensible when these things are not screened for. And then I'm like, we better get Pendle on the line to actually know what we should be looking for. Now, Jeff Klein talked about the Daniel score. Are you at all familiar with this, Pendle?
I'm not. I don't know.
All right. So the Daniel score is just they took a whole bunch of PE EKG findings and assigned point values to them. It scared the hell out of me simply because it's a lot of calculation. Like unless you had a AI doing it, it would be an enormous pain in the ass. But let's talk about it from a more clinically utile stance. So when you were screening an EKG for a patient who comes in with shortness of breath and chest pain, what are you looking for to know, hey, this could be a pulmonary embolism based on the EKG? And then we could delve further into which of those are signs also of right heart strain and which ones are independent of right heart strain.
First, I'll frame it as what I expect out of the ECG for PE, right? Very different than acute MI. In my experience and training, I'm using the ECG for PE only as a specific indicator of a bad PE, of a PE that's causing really bad right heart strain. The idea of using a Daniel score as part of my initial evaluation or initial thought process of whether I should work it up doesn't really enter my mind that much. I use it the same way I use bedside ultrasound for many things in emergency medicine, where I'm not an expert at that, but I use it as a specific finding that prompts recognition of a severe, obvious, immediate disease state. I don't use it at all for sensitivity, and that's backed up by the literature. I do look for right heart strain in patients I think it's relevant. I just want to make sure that the listener knows that I think it's useful for specificity. I can describe, and I will soon, the sort of classic right heart strain pattern. And if I see that, then I will act on that. But I'm not really looking too hard at the EKG for PE when I don't see that pattern.
Yeah, that makes sense. But you are screening all the EKGs in these chest pain and shortness of breath players. And then it's just a question of how much further you're going to go in terms of your consideration. Is that fair?
Absolutely. The findings that would be on this list, a lot of them just aren't really that helpful, right? Like sinus tach be the first one that everybody says, and so nonspecific that I can't really say that is able to guide anyone in a specific way. S1Q3T3, very common in normal people. So I don't really change directions in my clinical course based on that very commonly.
Well, let's pause there because I want to take these one by one. You're doing a perfect list. So sinus tach, obviously not specific for PE and not as sensitive as we thought for PE either, unfortunately.
Yeah.
That being said, you unfortunately will get burned if you don't explain a sinus tachycardia. So that one in a chest pain or shortness of breath player for me certainly makes me say, I'm going to really have to justify in my chart if I'm not going to do a PE workup. Obviously, the tachycardia already obviates PERC as a rule-out criteria. So now you're really left with a justification. And it could be, patient had fever. The fever is correlating with the degree of tachycardia. I feel pretty safe. But you damn well better be mentioning pulmonary embolism on that chart, I think is the bare minimum. And then let's talk about S1Q3T3. We know it's insensitive and nonspecific, and yet it's gone into the lore of pulmonary embolism. It's what we were taught as medical students. I think if they have that pattern, and again, you don't justify why you didn't work them up for pulmonary embolism, you're hosed. Is that your practice as well?
I agree. And even when I look in the literature, I find that it's not zero importance. I have some little nuggets here that I'll get to later, but some of these studies find an odds ratio or likelihood ratio somewhere in the 2 or 3 range, which is not useless. So what I'm trying to say is if it's a patient that I'm considering PE, absolutely all those things are important and I need to work it up or explain why I didn't care about these findings, right? But they're just so nonspecific that if I'm sure that it's not PE clinically, I'm not going to turn around and change my thought process.
Yeah, that's an absolutely fair statement if you're sure it's not PE clinically. And I'd add the additional statement, if you're not sure it's not, then I think that should probably prompt a workup with a D-dimer. unless you find an alternative diagnosis that really is compelling. And the case that I dealt with in the early part of my career was a patient who actually had an infiltrate and had sinus tach, and the infiltrate was vague. It was a vague infiltrate, and that patient wound up having a pulmonary embolism. And I must have told you this 100 times during our time when we were training together, but for me, when I say alternative diagnosis, I mean one you're willing to bet your house on. If you have, this is a dissection, okay, that's not going to be a PE. But if it's, I don't know, it's probably a viral syndrome, and they're probably they said subjective temperature, and that's probably why their tachycardic is there. No, that's vague. All right. So far we said sinus tach, we said the classic S1Q3 T3, and that is a right heart strain sign as well, right, Pendle?
Yeah, it is related to that. It's telling you that the QRS is changing a little bit because of that struggling right heart. And then the T-wave inversion in 3 is part of the, what I'll call the poster child, classic acute right heart strain pattern that I'll describe soon.
All right, what's next?
Well, let's just do that one. So the most important one to me is this sort of simultaneous inferior and anterior T-wave inversion that I can put in those words, but there's additional detail that comes with pattern recognition that is a little bit harder for me to describe, but I'm going to do my best, and I'm going to give you a link to one of our blog posts that has 10 of them in a row where we can just really train this particular little muscle in the EKG world. So it has essentially V2 through V4, I think, is the most important part of it for my subjective learning. And these leads usually have a QRS that has a little R wave, big S wave, followed by a coved kind of concave ST segment that then roller coasters into a big T-wave inversion. That pattern is, to me, recognizable as specifically right heart strain. And that happens in V1 through V4, and I usually find that it's most pronounced or important in V2, 3, 4. V1 kind of usually has a T-wave inversion for most people with normal QRS, so I don't find V1 to be the best lead, most important lead there. Now, based on where the right heart is, which I find this is usually the first time a resident that I'm teaching learns where the right heart is on an EKG when they see this case, because the right heart is underneath V1 through V4. It's also spatially represented by the inferior leads a bit because that right heart is twisted a little bit more inferior than the left heart. So lead 3 is that's why lead 3 is involved too. So for some reason, when the right heart has acute right heart strain, that is the way that it looks to me when I recognize it specifically on the ECG. So the classic PE EKG for me, the severe PE, is sinus tach, hopefully, usually, not always, and this simultaneous inferior anterior T-wave inversion with that small r, big S roller coaster ST T-wave inversion.
So you mentioned V1 through V4, the classic right heart strain. Then the inferior leads could be involved, and that would be 3 and AVF as the real ones you should be looking for. For whatever reason, what's come up in the literature bunch is, again, that 3 and AVF, and then V1, V2 as a 4-lead combination that had high specificity for right heart strain. I guess we're looking at V1 through V4 and 3 and AVF for those T-wave inversions?
Yeah, I'd say so.
All right. And how much of the pattern recognition really matters? Would you look at an EKG that had T-wave inversions in the anterior and inferior leads and just say, yeah, but the pattern's not right, so I'm not really concerned? Or is it that it's a agglomeration, and if you saw all those T-wave inversions, but you're the pattern's not right, but I'm still concerned? How much does the pattern matter, and how much does the actual anatomical location of those leads with T-wave inversions matter?
Oh, it's a perfect question, and I have a couple things I'll say in response. It's definitely pattern recognition is far beyond just the words, and I can prove that. One of the studies I'll talk about in a minute has an odds ratio of T-wave inversion V2 through V4 at 4.0, which is relevant and important. But I'll say that when an expert does this and sees that pattern with the way I described it, I think the odds ratio is a lot more than 4. And so there's a gap between the words and expert recognition. The other thing that I think you brought up is I want to give the listeners what I give my residents for an anterior T-wave inversion differential, because I think not all of the work has to be done by memorizing squiggly lines here, right? When I see an anterior T-wave inversion, and I'm talking to my residents about it, I tell them 5 things. So number 1, check and make sure it's not the QRS's fault. Okay, so abnormal QRS always causes abnormal repole. And the more abnormal the dipole, the more abnormal the repole. So everybody with a right bundle or any kind of big upward QRS in V1, 2, 3 is going to have T-wave inversions in those leads. and that's because of the QRS. Right bundle, separate topic. We'll do that in a second for PE. If you have a baseline right bundle, you're going to have T-wave inversion in V1, 2, 3. That's because of the QRS. That's number one on the differential. Number two is anterior reperfusion, or Wellens syndrome. This is hard to put in words about why it's different than the PE T-wave inversions. However, maybe that lead 3 thing helps with Kosuge's article. I'll show pictures of Wellens in the show notes too. Number 3 is acute right heart strain, what we're talking about, usually PE, but not always PE. Number 4 is hypokalemia, causes T-wave inversions, usually like a long QT with ST depression, downward T-wave, and then upward T-wave at the end. So down, up, long QT, down, up. That's hypokalemia. And Takotsubo causes big, impressive T-wave inversions sometimes when it does the classic thing on the EKG. So for those 5 things, usually the first one, the QRS, you can just tell immediately. And then you're left with a differential that is important, and you don't have to be an EKG whiz to figure this out. So an ultrasound is certainly going to be helpful in the most important steps of that differential. A patient whose pain is over and now they feel better points you towards Wellens, and a patient that has a huge right heart strain on their echo and has active symptoms is more like a PE. So there's ways to do that where you don't have to just be an EKG whiz, but that's my differential that I give.
I love that. That's fantastic. And it anticipated another question I was going to ask, which is, let's say hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Some of these PE EKG signs that are representative or putatively represented as right heart strain. So then you throw in the echo, and the right heart is like totally normal. Does that now obviate the likelihood ratio of those signs for pulmonary embolism? Or do they precede actual echocardiographic heart strain?
That's a great question. I would say that in my experience, I think that the echo is more sensitive for right heart strain than the EKG. Every time that I find this pattern I just described, I go to bedside even with my very mediocre echo skills, and it's the most obvious right heart strain that I could see. And I'm very primed for it because I think it's going to be there already, but the echo is usually severe when the EKG is obvious to me.
Gotcha. All right. That's super helpful. All right. What's next, Pendle?
Well, I do have some other patterns that I wanted to mention that are a little more complicated, so I don't want to annoy or scare people with it, but there are some other patterns that have tricked me in the past with PE that I wanted to mention. So number one is things get hard when the right bundle happens in PE. It's tempting to think that the right bundle is literally being stretched or affected some way by the strain, but for some reason, bundle branch block can happen in association with or maybe because of the acute PE. When that happens, a lot of the visual things that I told you to look for are now changed a lot by the abnormal QRS. And I lose a lot of ability to see acute right heart strain when the patient has that right bundle from the PE. So I feel much less confident that I know exactly what it is. But what I'll say in response is, if you have a sick patient who has a new right bundle, then I want you to be worried about acute PE and acute LAD occlusion. And so be very careful with those patients because I don't think that the EKG has quite the power that it does without the right bundle.
Okay, tell people, because I'm sure they learned it during med school and then promptly forgot it. What are they looking for to diagnose a right bundle on an EKG?
Sure.
Most of them are looking at the words on the top of the page to diagnose the right bundle.
Yeah, that's the problem, isn't it? And I'll say that you can have an incomplete right bundle or a complete right bundle with this situation. The complete right bundle, you'd have to have a wide QRS, which would be by definition 120 milliseconds for your QRS, so at least 3 small boxes. And the whole point of the right bundle is that the end of the QRS is wide and rightward. So the beginning of the QRS might be very narrow and normal looking, but the end of the QRS is the reason it's wide. That's because the right bundle is depolarizing late and last, and all of that QRS will rush towards the right ventricle. So you'll have the R prime, the big nasty wide R wave in V1, and you'll have the nasty wide S wave in V6, which is exactly the same thing in the other direction. Leads 1 and AVL will also have that wide S wave. And that's the definition that's how I find right bundle. If everything is just a little bit more narrow than that, it's not quite wide enough, you could call that an incomplete right bundle. And both of those are relevant for the situation.
All right. So just to recap, wide QRS greater than 120, an R prime in V1 and an S wave in V6 is a right bundle. And if it's not quite the 120, but it has that same pattern, then we could call that an incomplete right bundle.
Yes, I'll change one little thing. It doesn't have to be R prime. It just has to be a terminal R. Next thing I'll say is sometimes I've seen severe PE patients and their EKG to me looks more like global subendocardial ischemia rather than specific right heart strain. So global subendocardial ischemia looks like depression everywhere in most leftward and downward leads with reciprocal elevation in AVR. It really pains me that the EKG isn't showing right heart strain, but is showing global. I wish all PEs would just show me right heart strain, but for some reason I've seen terrible PEs with only that pattern to my eyes. So I'll put that on this too. And finally, the most confusing one I think for learners is when the supply-demand mismatch is so bad for any part of the heart, you can have a type 2 OMI pattern or a type 2 STEMI pattern. When that ratio of supply-demand reaches some critical level, it's functionally like there's no blood supply at all. And that looks like STEMI and looks like OMI. So you can see a patient who has an inferior OMI or an anterior-looking OMI, and it's actually a PE. It's rare and it's complicated, but I'll put it on the list.
That's petrifying. We're worried about going to the cath lab and missing a dissection. Now we could go to the cath lab and miss a pulmonary embolism as well. Now, those, while a little bit scary, don't concern me as much because I think where all of us are petrified is the patient who doesn't look sick. Like the sick ones, like we are going to do something. We're going to figure it out one way or another. We might miss it for a little while, but a lot of these could be presenting in a relatively silent patient. They have the chest pain or the shortness of breath that has brought them in, but they don't look super sick. And this is the real quintessential aspect of the case we posted that was so torturous, was the patient had normal vital signs. Yeah. And yet with an EKG, not just subtly representative of right heart strain, he had deep T-wave inversions in V1 through V4 and 3 in AVF. It was not subtle if you knew what you were looking for. And you might not know the answer to this, Pendle. How often does that happen? How often do you have a patient who's not having the vital signs you'd expect from a bad right heart strain and yet has the EKG? And we would have imagined the echo if we had done it on that patient.
Yeah, it's hard. I'm sure the real answer is scary. I'll say the one that has really petrified me over the years is the heart rate. I just, in preparation for talking with you, I looked through our old blog cases on PEs, and over and over, the heart rate's 85, and just not something that people would say is clearly corresponding with what they were taught. That one, that really bothers me. I've seen plenty of terrible PEs that are not profoundly hypoxemic. It's just scary, and it's just not the way to rule out PE, sadly. Even these EKGs with horrible looking strain, I got them over and over at 90 beats a minute, 70 beats a minute.
Yeah, absolutely. All right. Are there others, Pendle?
I think that's the most important ones to think about. Other than there's the idea of low risk, and I don't think it's a PE. And so we got to make sure we think about S1, Q2, T3 and tachycardia and like right bundle. And then I need to make sure I explain that I've thought about that. And then there's the other side of the spectrum where you're trying to recognize specifically terrible right heart strain. And that's the classic pattern I talked about. But that's, I think, the most important stuff about the EKG and PE.
All right. Let me share this because we'll get your impression. So this is the Daniel score, but just looking at it, it's pretty much exactly what you said, but they're giving points to these for relative weight, but you've hit all of them. So if nothing else, it would be a way to prompt people to check all these things when they're screening an EKG.
Where are you going with this? Yeah, this is maybe a tool that you could use as like a help you safely know when you need to explain an EKG finding for a patient that you think doesn't have a PE, I guess is what you're going for.
Yeah, just as a checklist, even if you didn't do the score, it might be helpful to people. All right.
I don't think that I could make a much better list than that. I think that's reasonable.
Yeah, the only things they don't have that you mentioned are the ones that are just signs of gruesome PE, which again, the patient would be so sick that I think would be recognized.
Those patients are sick enough that we're never thinking about the negative predictive value of those,
Absolutely. Hey, so future Weingart here. So should you be using the Daniel score in your clinical practice? I don't think so. It's actual purpose is to screen patients you already know are PE for prognostic signs, which really boil down to right heart strain. I think you're much better off if a patient has a PE throwing an echo probe on rather than looking at the EKG. So in terms of it as a scoring system, not so much. Now, what does the Daniel score actually boil down to? It boils down to these four things: sinus tach, right bundle branch block, either incomplete or complete, S1, Q3, T3, and the various components of that, and anterior T-wave inversions. I think, and this is just my personal opinion, I'm actually going to write to Jeff Klein and see if he could clarify his statements, but I think you should be screening every EKG for a patient who comes with chest pain or shortness of breath for those four things. And if they have it, it doesn't mean you have to work them up for PE, but it does mean you have to make a notation on the chart saying you recognize this is here, but you don't think this is a PE because, and then write something. I think if you saw these and you're like, I don't think this is a PE, it might behoove you, if you're not going to work it up, to throw an echo probe on, because I think if the heart is stone cold normal, then it obviates the new right bundle, the S1, Q3, T3, and the anterior T-wave inversions as being from a pulmonary embolism. Now, the sinus tach still remains, but you already knew that you have to explain sinus tachycardia if you're not going to work it up on a chart. There is a quote-unquote better ECG score, and it's called the novel ECG score, and I have it in the show notes. And when you see it in the show notes, you're going to be like, that is not clinically utile at all, because it is immensely complex. It is like, I think even Pendle would be like, this is too much. I think I need a break. So it might be something good for a computer to do. And in this time, I mean a real computer, not like a Pendle type computer. You know, if it was part of an EKG screening algorithm in the machine, I think it would be pretty good. The testing characteristics are much better than for the Daniel score and most of the other stuff we do. It's been validated once. I think you'd probably want multi-center validation before we said it was good for prime time, but it's a better score than the Daniel for screening for pulmonary embolism. But like I say, there's two separate algorithms, one for patients with and one for patients without a right bundle branch block. And then once you find which one, there's like 5 sections, and each of these sections has like 6 sections. It would be like your entire shift to use this algorithm. But you could check that out in the show notes. We also have a bunch of literature. We have cases from Steve Smith's ECG blog where you could see that were, stone cold normal vitals with horrible pulmonary embolisms, just like the malpractice case. So there's all sorts of good stuff. All right, I'll let you get back to Pendle to finish up the episode. All right, so is there anything else we should hit that we haven't discussed, Pendle?
I'm going to give you a bunch of EKGs to put in the show notes for kind of my differential T-wave inversion, because a lot of it's so visual. And the last thing that I wanted to riff on was listening to the case and your podcast of it. I wanted to emphasize how alone we are with EKG interpretation and expertise in emergency medicine and critical care. For every other image that we order, even if we're not the best in the world at it, there will be somebody that can help us, somebody who's more of an expert than us. Radiology, of course, for almost all the other ones. This is the only imaging study that we order where there are death threats that are in little squiggly lines that people have to recognize. And we in EM just don't have good training for it. The cultural average is so low for what's out there, and the ceiling is so high for learning ECGs. And we take everything else so seriously. A radiologist reading an image, or we spend years learning echo and emergency medicine. We have fellowships and boards. And this is the one image that no one will back you up on, and people will die from if you can't get good at it. So I just want to make sure people are scared enough, maybe.
I think after this, they're scared enough. That brings up another idea in my mind, which is there seems to have been a sea change in Steve Smith's writing on this that I've never seen before and I've seen recently, which is he had a very egalitarian stance on the ability of every emergency physician to gain true expertise in EKGs when I first started reading the blog. Mm-hmm. And now I read a post recently where he's like, it takes a very special subsetted person in emergency medicine to become truly expert at this. What do you make of that change in stance?
Steve and I, and mostly Steve, since 2008, have been trying so hard to teach all of this for free and to make sure that people understand that there's such a higher ceiling than is usually taught. And I know that we've affected a lot of people and made a lot of patients more safe by people reading and learning. But overall, it's hard to change the whole world. And especially with OMI, I think that is mostly about OMI is what he's talking about in that post.
I think that's right. Yes.
And we haven't made that much of a change yet because it's just so hard to teach this by person to person free online blog style. That's one of the reasons why we're now heavily interested in making AI do it, because it's just pattern recognition. It's just a two-dimensional squiggly line that has to be memorized. And humans can do it. Should humans spend their whole life doing it? Probably not. I'm a testament to that. So it's a job that seems so perfectly set up for AI that once that's available, the idea of spending years of every physician's training learning this versus using AI that's probably better than most of them, I think it does change the mindset a little bit. That said, Steve and I both want everybody in the world who's interested and motivated to learn this stuff, and we always will help them do that.
Let's really put your feet to the fire then. So, will there be a point in Pendle Meyer's life where it's so busy in the department that he just gets handed an EKG that already has the Queen of Hearts interpretation on top and doesn't bother to look at it?
Oh man, that's painful. I think that will happen for years farther than it should. We'll put it that way.
All right. All right. I can't thank you enough for coming on the show. It's great to talk to you, brother.
Thanks for having me.